Well, good afternoon, everyone. We'll go ahead and get started for today. Welcome to our fourth webinar in the Back to Basics and Beyond series. Today, we are going to be focusing our topic on the importance of immunizations for those with chronic diseases. So for those of you who have joined us before, we're glad that you are here again. And if this is your first time joining our series, we're so excited that you've decided to join us today and happy to have you. So this webinar series, the Back to Baseline and Beyond Post-COVID Management of Patients with Chronic Conditions, is really focused on helping healthcare providers across the continuum of care use the lessons learned from the pandemic to really improve chronic disease management for their patients and improve health outcomes. So what we would like you to do right now is to just take a moment, please add your name, your organization, and your role in the chat box, so that way everyone can know who is joining us this afternoon. And I'll just go ahead and introduce myself. I am Andrea Boucher. I am with the Superior Health Quality Alliance Chronic Disease Management Team. I will be your facilitator for this afternoon. And I am also joined by Kristen Bosch, Gray Ficker, and Jerry Hineker from Superior Health as well. So I'll give a little bit of a background on each of our speakers. I'm really quickly going to go to the next slide. All right, and Kristen is a clinical quality improvement manager with the Wisconsin Hospital Association, one of our partners in Superior Health. Gray is an epidemiologist, a healthcare analyst with Improve Health, one of the partners based in Michigan, and has experience in evaluating chronic illnesses and disease management. And Jerry Hineker is a program manager with Stratus Health, based in Minnesota, and she has experience in assisting providers in primary and secondary prevention and management of chronic diseases. So I will go over our objectives for today's session. We will focus on appreciating why vaccines are important for people with chronic conditions such as diabetes and cardiovascular disease. We will also talk about the vaccine adverse event reporting system and its limitations. You will gain techniques for talking with patients about vaccines to encourage vaccine acceptance, and also understand current vaccine recommendations for influenza, pneumococcal, and COVID-19. So our agenda, what that looks like for today, first we'll touch on chronic conditions and vaccines, then we will go into the VAERS reporting system, and then we will cover clinical immunization safety assessment project and also the vaccine injury compensation program. We will then move into talking about techniques for talking with patients and go over current vaccine recommendations. At the end, we'll have some time for questions and open discussion. So if you do have any questions throughout the presentation, you can feel free to add them in the chat box. But with that, I am going to turn it over to Kristen.
Thank you. So we'll begin with chronic conditions and why vaccines are important for those populations. So to begin, chronic disease can make it harder for your immune system to fight infections. You are at risk for more serious complications from an illness compared to people without that chronic condition. The immunization provides the best protection against vaccine-preventable diseases, and one of the safest ways for you to protect your health, even if you are taking prescription medications. Additionally, we have vaccines protect you and your loved ones from many common and serious diseases. The potential costs of getting the disease, including serious health effects, such as the time lost from missing work or family events, and the financial costs. And lastly, it can worsen your chronic condition if you do contract the disease. Some of the risks involved for unvaccinated, looking at pneumococcal, is that those who get it, pneumococcal bacteremia kills 1 in 30 children and 1 in 8 adults, while pneumococcal meningitis kills 1 in 12 children and 1 in 6 adults. And the CDC supports that being up to date with the COVID-19 vaccine to provide protection against infection during the emergence of the Omicron variant. Adults were 5 times higher risk of infection when unvaccinated compared to those who were fully vaccinated and with a booster. In the 2019-2020 flu season, the CDC estimated the flu caused 22,000 deaths, with nearly 52% of the US population 6 months of age and older getting a flu vaccine, preventing 6,300 deaths, which averages to 12 lives saved per day over a year. And these graphs represent the comparison of cases on the left of COVID-19 to deaths on the right, in those unvaccinated with the solid line, fully vaccinated with the longer dashes, and fully vaccinated without the booster with the dots, and fully vaccinated with booster with the dash and dot. The colors across the scale of white, blue, and gray represent the various variants of COVID-19. Our y-axis represents the events per 100,000, while the months are denoted on the x-axis. We can see that the unvaccinated populations have remained significantly higher than those who have some form of vaccination and protection, especially when we look at the incidence of deaths. And on this slide, we're looking at the influenza burden estimates shown here from the severe 2017-2018 flu season. As we know, the flu viruses change constantly from season to season and sometimes within the season. Thus, the reason for changes made to the vaccines to keep up with those changes. The seasonal flu causes substantial sickness and death, with the U.S. flu burden each year in the 2010 through 2020 resulting in 9.3 to 45 million illnesses, 140,000 to 810,000 severe cases and hospitalizations, and 12,000 to 61,000 deaths in those that were unvaccinated. And next, we'll kick it over to Gray. Gray, you're still muted.
Thank you, correct. So I'm going to be reviewing VAERS, that's the Vaccine Adverse Event Reporting System, which is a subset of the CDC Wonder data, or basically all the data that is reported through their website. It's used as a national early warning system, and it's used to report possible side effects following vaccination. It is not designed to determine if a vaccine causes adverse events, but it can help us identify unusual or unexpected things if we look at the patterns in not only how things are reported, but also what is reported. And it can help us look at potential safety issues moving forward and see if there's something in the data that we missed that might come up through different ways that we might explore. And I'll be talking about some examples as well. So, and I'll get through as many as I can in the time frame, but they are there if you need reference, and I can always be reached through email if you want to follow up as well. So the managing agencies for VAERS are, of course, the CDC, and then also the FDA and the Department of Health and Human Services in the US. And it covers all our data from US state and territories that's reported, and it accepts reports from anyone. And this data collection is basically a form that is online, and vaccine manufacturers are required to report any type of events and all events following a vaccine administration. And then providers can also report things, but any individual who experiences something or perceives they might have experienced something can also fill out a report for themselves. And so you need at minimum to collect information about the vaccine, the person who is vaccinated, and then the adverse event. And this is all publicly available, which has its advantages and has its disadvantages. So what you would do if you want to follow up for a report as well, because it allows people to do duplicate reporting or add to existing reports, is you get a specific identifying number, and then you use that to look up your report and then file and continue filing. So, but keep in mind that if something is, fraudulent, or there's clearly an intent to give misinformation or to do a claim that is false, then it can be identified through the CDC and the FDA and will have legal consequences. So, but let's talk about some of the limitations along with the strengths. The limitations are there's no causal relationship between the information reported through VAERS and vaccines. So it is purely associative. And that means while there is, that's probably the biggest limitation, those strengths are there to, again, give us a sense of scope and a sense of limitation, but it is still valuable to collect. So that's why we do it. And publicly available information can cause confusion, and it can specifically be associated with death and then really intense health events, such as like disfiguration or things like that. It's associative. Even if something we know, like there was a shoulder injury that was reported following a vaccine, and that's clearly not a causal relationship. There was a death that was reported 995 days after a vaccine administration that was not associated with the vaccine. So people easily misinterpret VAERS reporting of deaths and also any kind of events that would follow as being causally associated with the vaccines rather than just a coincidence or the risk of having a life and going through life. So VAERS accepting all reports of health events following vaccines, and it doesn't judge. So at least you know that if you do report something, regardless, you don't have to worry about whether it's going to be something that they need caused by the vaccine. You can just report it. And you can change and update your claims and your reports. So to correct things, and keep in mind that the requirements are stringent for manufacturers and for providers. And that's why it's important, because that's for experts and national policymakers to decide whether they're going to act and continue to investigate on those. So next slide, please. Thank you. And so there's a lot of extremes that go into these reports. They can either lack a lot of detail because you only need those three things: the name, the type of vaccine, and then the information on what happened or potentially happened. But they can also be extremely in detail and lengthy. I mean, there's vaccine reporting and it's changed over time. So you have to really look through things. And then they're going to have a lot of errors because humans. And it's also, we got to keep in mind that just like with volunteer bias, if something is more serious, it's more likely to get reported. And so it's going to look more intense than it potentially could be. And we also have seen an increase in reports after social media attention or just regular media attention has been given and through public awareness. So the coronavirus vaccines account for about 50% of overall VAERS reports, which sounds bad, just face value, but we got to take into account that VAERS reporting has been available since 1990, and the COVID-19 vaccines have only been around since 2020. So with those 2 years, it's very unlikely, especially because vaccines are an established, well-known fact that it helps, and there are very low risks and very low incidence of events that actually happen. So it's very unlikely that all of those are directly associated with the vaccine. And VAERS, again, cannot be used to determine accurate rates of adverse events or multiple events. And there's often going to be missing information as well. So again, there's no way of knowing if vaccines cause any adverse events using VAERS alone. And then next slide, please. So like I was talking about, there's been, just to give some parameters for the next slides, there's been about 1,617,912 unique VAERS reports as of July 29th, 2022, when I pulled the data. And this information is reported weekly. It's collected on a weekly basis and put publicly available onto VAERS. And like I said, 55% or 896,864 reports are available for COVID-19 vaccines, and that is a significant number. So we want to keep in mind that also when you're pulling these reports, there's only so many things that you can do at one time before it times out. It's kind of difficult if you don't know data science and if you're not familiar with the reporting tool and the actual data set itself. So it does take some time, which can cause additional confusions. Let's move on to the next one. So we can see right here for the flu, COVID-19, and pneumococcal vaccines as of July 29th, 2022, we see that there's over 100% reported for those for that rate, and that is due to a 9.13% of the reports would be repeated reports or follow-ups. And then we also see how 65% of these reports are none of the above. There's no associated event that was listed above, and those are pretty serious and pretty standard issues. We also see a lot of emergency room and office visits that could be associated with simply taking care of your health or having a health event that's unrelated. So we don't know. And then next slide, please. And same thing here, where it is specifically for COVID-19 vaccines, the same date parameters. And so we've had, and then I changed the dates to match up with when COVID-19 has been available, not necessarily when VAERS reporting has been available, since VAERS has been since 1990, and COVID has only, 19 vaccines have only been available since 2020. And then again, 66.91% of these reports were none of the above health events. So it's very, very unlikely. And then you have some repeated that there was anything to do with that. So next slide, please. Okay, and then for influenza, the influenza vaccines have been available long before 1990. So we keep that in mind as well. And then we see only a 7.84% of reporting or follow-ups from those, and still a very high number of 63.55 events reported were none of the above. So next slide, please. And then here we see pneumococcal vaccines, and emergency room and office visits are about 30%, so it's a little bit higher. And pneumococcal vaccines are only given to populations that already have a higher risk and some health events that they are managing. So it is good actually to see that so many people would be going to their doctor, or they might have been administered at the emergency room. We don't know. And then none of the above, again, really high at 57% about. Next slide, please. And then this is for all unknown vaccines, not just for pneumococcal or flu and or COVID-19. But we see here for all of the vaccines reported unknown, none of the conditions above or none of the event categories above would apply for those either. So that's really consistent. When we start to see patterns like that, you want to question what it's about, and we'd have to do a deeper dive and see each individual claim and look into that to really get a sense of what might be going on. Slide, please. Okay, so just like I talked about before, I went onto the CDC website, and it'll ask you if you're going to make a report for VAERS, have you had a reaction following a vaccination? And it'll tell you to contact your health provider, and then it gives you the downloadable form that a provider can also fill out, and then to contact 911 and let the CDC and FDA know if you need additional assistance and more information about that. But I have a link here in case you want to look at that report form yourself. Next slide, please. So legal requirements are listed as well on the CDC website for VAERS, and I have the link here. And any adverse events listed by the vaccine manufacturer that might have an interaction that's harmful to further doses of vaccine, they all have to be reported. So like I said, it's a requirement that vaccine makers will report anything that follows a vaccine, regardless of whether it actually is caused by the vaccine. But especially if it's contraindicated, they will report that as well inside their report. But there are separate ways to report whether it's associated or whether it's caused. And so we'll keep going with that. I'll talk about that a little bit more moving forward. So we strongly encourage providers to review VAERS reporting in the sense that we want them to be able to have access to it and understand that their patients might have access to it. And it's a potential location or reason for a lot of misinformation or issues with clarity or interpreting data. And we just want to emphasize with our patients and other providers as well, because some staff and providers don't realize this either, but any licensed vaccine that's administered in the US can be reported or is reported through VAERS, whether or not it is clear that the vaccine caused infection. And there are a lot of administrative errors. It's required that all adverse events are reported by vaccine manufacturers. And I might sound a little bit like a broken record, but it's because these are the talking points and we want to help people emphasize that. So again, moving forward. So here's some solutions. The CISA and VICP. The Clinical Immunization Safety Assessment is the CISA project. It was established in 2001, and it provides comprehensive vaccine safety public health services. So this is where we do want people to report things that have been verified that were caused by the vaccine, and you can get more reliable reports from this place, but it's not publicly available to everybody. You can make specific data requests. So this addresses the unmet vaccine safety clinical research needs of the United States. And it's made up of a national network of vaccine safety experts. So Immunization Safety Office, part of the CDC, 7 medical research centers, and then additional partners. And then, of course, the question is always, who are they? And in quotes. And so I have some information about that as well, moving forward. And so we see on this map here, it's everybody from Boston Medical Center, Columbia, Johns Hopkins, Duke, CDC itself, Kaiser Permanente, and then of course our Cincinnati partner in the Midwest. And then the next slide has the other map that has the data link partners for vaccine safety on our map here. So it has yet more facilities. So these are the actual facilities and the actual partners. This is who they are. So again, let's move forward. And that's available on the CDC website as well. So the Vaccine Injury Compensation Program is for people who have legitimately experienced something that was caused by a vaccine, a patient that did experience a vaccine-caused health event. I wanted to have this information available in case you or anybody else that you know or your patients do have needs that and require compensation and a pathway for that as well, and to answer concerns and questions and if patients are worried about that. So I have a link to the website there and then the phone number to contact them as well. And this is separate from VAERS and CISA. It's administered by the Health Resources and Services Administration, and you can report adverse events to VAERS, but again, it doesn't constitute, it's not the same thing as filing a VICP or a Vaccine Injury Compensation Program report claim. So that's where we want people to go to do that. Okay, and next slide, please. So these are some resources for providers and patients. We have some brochures, and then the National Center for Immunization and Respiratory Diseases has more information. The CDC has some great websites and presentations and videos for talking about vaccine safety, and you can review those. But keep in mind, it wasn't updated, and the last time it was updated was March 1st, 2021. And so I will move on to the next. Hand it over back.
Thank you, Gray.
Thank you.
And so now we're going to talk about different techniques for talking with your patients to encourage them to get the vaccine or consider getting the vaccine. And here are just a number of different strategies that I'm going to cover during our presentation today. I'm not going to go into great depth on each of them, but just kind of wanted to introduce them. You can actually find all of these different strategies on the CDC website. I have the link there at the bottom of the page. And I'm going to start with provider recommendation. And provider recommendations have always been out there as a strong, or have always had strong support. And I think during COVID, we saw that maybe the provider recommendation wasn't as strongly accepted due to different reasons. But really it is kind of still that first line. It's recommended by the Advisory Committee on Immunization Practices. And some of the things too, when we're looking at provider recommendations, is just to remember to talk with every patient about vaccines, and make it part of, how can it be part of that visit every, especially when we're talking about flu vaccines during the flu season, to encourage patients to get their flu vaccination if they haven't already. And when we're talking with patients, make sure these kind of the next 4 points just go really hand in hand. So listen with empathy, listen to those concerns and acknowledge those concerns that the patient brings forward when as to why they may not want to get a vaccination. When you're talking to them about getting vaccinated, ask open-ended questions, not yes, no questions, but those things that will help pull them into the conversation. So why is it, if they're not getting the flu vaccine, why is it they're not getting the flu vaccine? Is it because maybe they have an allergy, or maybe they just don't believe in it, or but finding out what it is, their reasoning behind not getting that vaccination. And then this will help you target your conversation when you're working with that patient, as to, to bring out those facts, as to encourage them to get the vaccination. The next point here is motivational interviewing. And I'm sure all of you have probably, or maybe you haven't, but motivational interviewing has been out there for working with patients for a lot of different the chronic conditions, especially for maybe like diabetes or heart failure, and targeting the patients, what are their goals for the outcome of the session. So really it's patient-centered. It's those conversations are designed to increase the patient motivation and the likelihood to uptake that health behavior. So it's working on their goals. So why is it that they want to get, or why is it, maybe to start with, why they're not getting an immunization, but why is it, what would they see as the reason to get an immunization? And we do have resources that will be listed at the end of this presentation about motivational interviewing. And next is medical. The next strategy is the medical provider vaccine standardization. So for here, looking at standardizing or doing standing orders within your clinic setting, so that, it's just part of, again, that routine visit, so it's ready to go. One option that we've been hearing more and more about is that offering the vaccination as a default option during patient visits. So it's more like, okay, you're here today, they could be coming in for a diabetes recheck, but it's during flu season, and say, you're here today, it looks like you haven't had your influenza vaccine, we've got it ready to go, are you okay with getting it, kind of thing. So that, avoids the, oh, you need a flu vaccine, okay, well, check with somebody, we'll get you scheduled and you have to come back in, kind of thing. So having it like ready to go so that they can go and have the vaccine right away when they're there. And also just integrating the vaccination process into other medical procedures or practices too. So it just kind of becomes part of what you're doing in your healthcare setting. And there's also medical reminders, and that's sending messages out to the patients. And this can be just as part of, maybe they're coming in again for a check of their A1C, but hey, we saw you haven't gotten I keep using flu as my example, but you haven't got your flu vaccine. So let's, do that while you're here. So you can use a number of different ways for those reminders for patients. It could be, a phone call, it could be a text message, you can send them postcards in the mail. A lot of health systems, have the things like my chart where it kind of pops up. I get an email saying, hey, you're due for your vaccine. I can just go and schedule it online. So using those medical reminders is a good way to help keep our patients on track with their vaccinations. Next, I want to talk a little bit about that effective messaging. And so as I talked a little bit earlier, a lot of people saw their providers as a trusted person. And if their provider said to get a vaccine, they would get it. That dropped off a little bit during COVID, but who else can we use as our trusted messengers? And so this, in the message, it's not even the trusted messengers, but also the trusted message and who that comes from. And so the messages that you want to use are those that have undergone testing with the intended population, because different populations have different reactions to our messaging, and why some groups are just, okay, I'll go get my vaccine. And I think everybody needs to understand why it's important for them to get the vaccine. And so using those different messages, like maybe it's for younger people so that they can stay healthy and take care of their kids, because if they get sick, their kids might get sick and they won't be able to do that and take care of their families. So I think we have to look at, it's not one size fits all. So the message has to be targeted towards different populations. And then again, using those trusted messengers. So maybe if it's not the physician, is that, the minister, at their local parish, or, is that someone else in their community who's a trusted messenger. So we saw this being used quite a bit during COVID, also for getting people vaccinated with the COVID vaccine. So I think that's another thing we can use it also for influenza and pneumococcal. And then just a little bit too about vaccine ambassadors. And these are community members who have been trained to disseminate the important health information in their communities. So again, immunizations is important health information. So using those people, again, who've been trained to talk to those in their communities about different healthcare situations. They can be doing that for immunizations too. Community health workers might be a great example of this. I just want to keep moving here. Another way to, or another strategy is financial incentives. And I think this has been something that's probably been used for quite a few years, not just during COVID, but we did again see it coming to light during COVID. And the financial incentives, they can take two different approaches. So maybe it's if you come in and get a vaccine, you're going to, we're going to give you $10, or we're going to give you a gift card to some store such as Target. So they come in, they're rewarded for the behavior. There's another way to do it too. What we saw a lot of, I think, was it Ohio, used, the funds that they got in their state, they did a lottery. So if you got the vaccine, the COVID vaccine, your name was put in a lottery for $1 million. So there's different ways to look at doing these financial incentives. And, they have some effect, it's not like 100%. I think we saw in some, with the lottery, there was a lot of interest at first, but it didn't work the same in every state. And so it worked real well some places, maybe not other places. So you just have to look at your audience, and if this is something that would, promote them to go and get a vaccine. Also home delivery vaccinations. We've seen this could be like home care. It's meeting those people where they're at. It's usually used for the patients who have barriers to maybe coming in for a vaccine clinic or coming into a clinic, those who are homebound. So we can do this through home care agencies. If they're already receiving home care, we can bring a vaccine out to them. Or for other populations, maybe they're not receiving home care, is there some type of delivery method that we can make sure that they are getting those vaccinations in the home if they can't come in and get it done. And then lastly, looking at combating misinformation. And I just want to talk about, so there's we're talking about both misinformation and disinformation, and again, how it relates to vaccinations or immunizations. And so there are strategies that we want to use in combating both of these situations. Misinformation is false information that can be shared by people, but usually it's not intentionally meant to mislead people. So it might just be somebody, you hear somebody talking about, somebody had a bad reaction to a vaccine, or, that, there's ingredients in a vaccine that can cause harm, those kind of things. So you hear it, you can hear it in a conversation, you can hear it on TV, you can hear it on social media, but it gets spread, and it's not meant to mislead people, but it's still very harmful for people to get immunized, because if you're hearing this from somebody you trust, then without being able to check the facts, you might not go out and get a vaccine. Disinformation is that information that's false, and it's spread with the intent of to manipulate people, or with malicious intent. So we got two different kinds. It's misinformation, disinformation. For both of those, especially for providers or those trusted, the ambassadors, it's being able to fact check or debunk are kind of the two main ways of looking at this. So be prepared with factual statements. So you kind of have to know what all the myths are out there, but how you can, again, listen with empathy, listen to what your patient is saying, but then that you can provide them with actual information and probably even cite the actual information as to why what they heard is not true. And I think that is all. I'm going to turn it over to Kristen for vaccine recommendations.
All right, so we're going to take a look at, in the next few slides, for current vaccine recommendations for influenza, pneumococcal, and COVID-19. So the first one that we will be looking at is the influenza vaccine, and the table here indicates the appropriate vaccination of influenza for the inactivated, recombinant, and attenuated, all of which are recommended 1 dose annually. And then we have the pneumococcal, and the following table indicates appropriate vaccination of the pneumococcal of 1 dose. And you see the age ranges there. And this gives a broad view of the 3 types of the COVID-19 vaccines available and when the most appropriate dosing schedule is. We'll break it down for you in the next slides. We have the mRNA vaccines. This is Moderna and Pfizer, and also known as BioNTech. And you can see that it has dose 1 and 2 to administer. And these are with our 18 years and older age group. And we can go to the next slide. And we have the protein subunit vaccine. This is Novavax. Again, 2 doses. And on the next slide, we have the adenovirus vector vaccine. This is the Janssen. And we have the age range there of 18 years and older. And on the next slide, these are the vaccines that are licensed and available in the US. So we have our Moderna, Pfizer, and Johnson & Johnson, and the FDA-approved vaccines. And then vaccines available outside the US, all of them are listed there. And our resources for the vaccine toolkit and any information you may look to gather for quality measure tip sheets on influenza, pneumococcal, and having strategies for vaccination readiness. Okay.
All right, well, thank you all for the presentation. I think at this time, we will go ahead and pause and see if there are any questions. If you do have a question, you can feel free to unmute and ask, or you can add it in the chat box. So I will pause for just a minute, give you a little bit of time if you have a question.
Tracy earlier was asking me about how to, like what would need to be included in, for example, the vaccine adverse event for a victim of someone who actually did experience a bad event. So we reviewed some possible necessary information and how it would be a good idea to consult with your doctor and even maybe a lawyer and have your doctor help you out with advocating for you in those kinds of cases and including as much medical and verifiable detail as possible, which is a lot of work. So that's why it helps to have extra support.
Great, thank you, Gray.
Well, thank you to Tracy for the question. So hopefully someone else.
Great. We don't see any additional questions in chat, so I think we'll move into our discussion questions for today. So we have a few, and we'd love to hear your responses for these questions. So again, if you want to unmute and chat through these responses, or you can feel free to add anything in the chat and we'll read those out for you. So our first question is, what types of engagement strategies do you use when talking with patients about vaccines? So what strategies have you seen be successful in your organization? Has anyone had experience in using any of the engagement strategies that Jerry had talked through on today's session?
This is Sheena. I'll admit I might have had to step away for a couple minutes, so maybe you talked about it a little bit. And full disclosure, I don't give vaccines anymore. I do the clinical build. But for ours, we have just like protocols in the clinic that nurses can give certain vaccines. So they talk through a lot of them. And then we can give it to them before the provider goes in there. And if the patient has questions on it, we just make sure that the provider knows, like, hey, this patient has questions about, well, like why they need the pneumococcal vaccine. I tried answering them. And then usually the provider ends up, talks to the patient a little bit, agrees, and then they end up getting it. And, we just talked a little bit about side effects and that sort of thing. So.
Yeah, that's great. Thanks for sharing. I think you kind of covered a couple of the strategies that Jerry had covered today, really that provider recommendation, and also, just integrating that and offering a vaccine during that medical appointment as kind of like a default option. That's really a couple of great strategies it sounds like you're using. So thanks for sharing.
Yeah, we've also implemented some drive-through clinics too. It came in handy when for the flu season last year, and now we've just kind of expanded our drive-through clinics for patients to get, just did a pneumococcal one, and now we're doing a Tdap one, and then a Shingrix one coming up too, or the zoster.
That's awesome. That's really a great convenience that you're able to offer your patients. So thanks for sharing that.
I got a question here that was asked, that I asked this anonymously, just to let everybody know. So it seems that most of these strategies are being publicly addressed, and the hesitation seems to be over political lines. So how are public government organizations trying to combat this issue? And I have some ideas, but I would hope other people would talk first. Okay, so when that happens, because it is going to happen and it comes on both sides, and I talk about this in some other presentations as well, if people want to go review other presentations on our YouTube site. I believe we have a YouTube site, or on in the webinar series itself as well. My first thing that I do, no matter who I'm talking to, is listen and let them talk through their concerns. Let them list them, let them go through their thought process, because that way I can tell better what exactly their concerns are. And then I'll keep my ear out for specific rhetoric, like basically specific terms that I've heard in the media, or through my research and this kind of research, and see if I can pinpoint exactly where that is. So meeting them where they are. And so even if I'll hear people say things that I think are very outrageous, and I'm someone who typically people think is a little outrageous just because I have a big personality. So I try to let people know that it's okay to express their concerns. Anytime you talk to a doctor or health provider, you should have confidentiality, as long as you're not trying to harm yourself or someone else. And that it's okay to be different or have different viewpoints, but what is the difference between risk and likelihood, right? If something could have happened, that's very different than, oh, it's definitely going to happen. And that might, the way we look at the world can be viewed and can be shaped no matter what kind of difference or what experiences are. So instead of continuing to make things political, it can help to emphasize to people, you're not alone. And we collectively, doesn't matter what you feel like happened or is happening, we know something's going on. So at least take comfort in that. Those are the kinds of things I try to do. Hope that's helpful. And if the person who asked me this has any additional questions along with that, please let me know too, and the rest of the group too.
Thanks for that input, Gray. All right, I think I'll go into our second discussion question for today. Looking at approaches that either you are planning to use or maybe you already have in place at your organization to implement a successful vaccine program. So does anyone have any comments on how you've made a successful vaccine program in your organization? You know, we heard a little bit about the drive up vaccines made available. I think that's a really helpful strategy or approach that can probably lead to success. But if you have any comments, feel free to unmute or you can drop it in chat.
Along with the drive-in, someone else mentioned that they're doing home health visits at their facilities too.
Yeah, that's definitely also a great option.
Yeah.
Does anyone have any, resources that you might need or any way that the Superior Health team could support you in a successful vaccine program? You can always feel free to, reach out to us individually offline, or if you want to reach out to us during this session as well.
Or two, if any of those on the call today, especially those talking about their drive up or drive through vaccine clinics, if there's, people would like to learn more about those, if there's a way that, they could share that information, I think that'd be great.
All right. Well, I know it's late in the day, and since you guys are a little quiet today, I'll go into, if anyone has any responses to our last question, looking at tools that you could use to help your patients manage and track their concerns regarding vaccine safety and management. So are there any tools that you are already using or anything that you think would be helpful in this area?
I mean, this is a good opportunity if there's something you want Superior Health to develop for you. And one of the resources too on the previous slides too is there is a toolkit out there, and it's for pneumococcal and influenza and COVID specifically. But if you've ever had a chance to look in that toolkit, it's got sample letters and sample messaging, anything, some of that information, so you can relay if you're a home health agency, that you're relaying that message to, a primary provider. So that's just one thing that Superior Health has out there to help you. But, we're certainly here if there's other tools that you need developed.
Thanks, Jerry. Well, if there are no additional comments or if there's no questions, I just have a couple of final slides to wrap up today's session. So we do have an opportunity where you can continue the conversation in Superior Health Connect. And Connect is our platform for really a shared learning environment where all of our participants, your colleagues, you can come and connect together And it's really about an all teach, all learn environment. So it gives you the framework to improve and sustain all of your mutual healthcare quality improvement initiatives locally, regionally, and also at the national level. So if you are not yet connected with us on Superior Health Connect, there is a link on this slide, and you can go directly into that and enroll on there. So what is next for everything? So our future topics, as we noted, this is a webinar series. So these webinars are hosted on the third Tuesday of each month. And currently they are both at 12 p.m. Central, 1 p.m. Eastern, and then the second session at 3:30 p.m. Central, 4:30 p.m. Eastern. We did want to open up a polling question for you all. We want to make sure that the timing of these sessions are really working and are beneficial for all of you. I know for those joining from the Eastern time, it's a little later for you in the day. So we want to make sure that the timing of these are really the most valuable to you. So please answer the polling question in the chat, either choosing between 3 p.m. Central, 4 p.m. Eastern for this second session, or keeping it at this same time. If this time works well for you, you can suggest to keep the time as is. But we really appreciate your feedback. Again, we want to make sure that these times are helpful for you. We are going to definitely, if you're mostly interested in moving it to the 3 p.m. or 4 p.m. Eastern time slot, we will do our best to change that. We can't make any promises, but we will definitely work towards that if that's what works for most attendees. But I did just want to note, and we'll keep the polling question open if you have not yet been able to respond. But on this slide, you can see all of our future topics that we're going to be discussing through next February. Next month, we're going to have a focus on how to take a blood pressure. So some of these topics are subject to change. If there is something that's a little more time sensitive, we may move the schedule around, but this is what our plan is right now through the end of February. And we do have some next steps for you all today. If you are not currently registered for the September session, please go ahead and do so. Our registration links are on this slide for both that noon to 1 time slot and then the 3:30 to 4:30 time slot. You also, as I mentioned, can sign up for Superior Health Connect. That's our platform where there's a ton of resources available to you and the opportunity to connect with your colleagues that are also participants with us with Superior Health. I also wanted to put a plug in for signing up for one-on-one calls. So if you are interested in a little more detailed assistance and are just looking for just more support for your organization, you do have the opportunity to work with one of the quality improvement advisors from Superior Health. So if that does sound of interest to you, feel free to email Jerry, and her email is on this slide. And you can always reach out to anyone on the Superior Health team if you do have any questions. And lastly, I did just want to mention a program that we have going on right now with Superior Health. It's our Shine a Light on Stigma campaign. And this is really about substance use disorders and how many patients who have substance use disorders can oftentimes feel shamed or judged by the stigmatizing language that's used around it. So this could result in doubts that they can or will receive treatment that they need. So really an important strategy to address that stigma is to become more aware of how those words and how the language that we're using around it does impact the feelings of those with substance use disorder, and then also our actions in regards to how to address those issues. So there is a 4-step process for you to take the pledge and get involved in the Shine a Light on Stigma campaign. And this is both for organizations, you can do it at the organizational level or as an individual, to sign the pledge to use non-stigmatizing language around substance use disorders. So we do have a link on the slide if you are interested in taking the pledge. Also learning about stigma, listening to the stories of people who have that lived experience. There's a link for that resource on this slide as well. The third step is really starting to use that non-stigmatizing and person-centered language. and then sharing Superior Health's website and media toolkit with others to get the word out about this really important campaign that we have started here. So with that, that is all I have. I will pause if anyone has any final questions or if anyone else on the Superior Health team has any final comments for today. All right, well, hearing none, thank you all for spending your afternoon with us. We appreciate you and hope you have a great rest of your day. Thanks, everybody.